So just a few disclosures. I do consulting work for Zimmer Biomet on health disparities, and I'm a consultant to a Swedish company that makes bone substitutes called Bone Support. So we touched on some of this yesterday. Health in the USA, obesity, and rates of obesity vary based on ethnicity. So we can see that in particular, and there's no one group that gets to hold up a flag and say, I'm good, okay? Everyone's bad. It's just some groups are even more impacted, particularly Hispanics and African Americans in terms of obesity. We talked yesterday about how every 10 extra pounds is another 30 to 60 pounds of pressure on the knee joint. This is particularly impactful for women because women have higher rates of obesity. They have a higher burden of knee pain and knee osteoarthritis. Physical activity, if we want to look at this declining rate of physical activity, so if there's two things that we could do across the country that would dramatically change healthcare, it would be address obesity and increase physical activity. And you can see this declining rate over the years, and then you can also see that there's also some race and ethnicity differences. So if you're going to improve the health, we need to address obesity and physical activity, and to combat obesity and increase physical activity, we need to focus on musculoskeletal health. And then we need to engage patients to be active in their health journey, right? So if we're going to address these two fundamental issues that are driving poor health and bad outcomes, patients need to be engaged and part of that journey, or the change won't happen. So I want to talk today about one tool and then our Operation Change program. But this is, the shared decision-making tool is something that you could take home and you could do it Monday. You could, well, maybe not Monday, we would set up, a virtual session with your team and help walk you through the tool a little bit more, but it's very easy to use. So what is shared decision making? It's a collaborative process that allows patients and their providers to make healthcare decisions together. And the critical thing, unlike what we would say is informed consent, right? Tony's going to do an operation on a patient, he talks to the patient about the risks and benefits, that's informed consent. What's missing from that conversation is taking into account the patient's values and their preferences. And that's what differentiates shared decision making from other processes like informed consent. That's really important because we know there's a lot of paternalism in medicine, which is, I'm the doctor, I know what's best for you, I'm going to tell you what you should do, and you should listen to me, and then you should do it. Right? Well, that's just not how people work. And for any of us that are parents, it's certainly not how our children usually work, right? So we really need to approach how are we going to engage patients on their health journey by pulling in the opportunity to use shared decision making. Okay, lots and lots of benefits of shared decision making. Reduces decisional conflict, worry, or anxiety about the decision. So if a patient is engaged in shared decision making, they feel more confident and secure about their decision. Increases satisfaction with the decision, improves the provider-patient communication, and most importantly, this last bullet point, improves patient willingness to undergo treatment and completion of treatment. Because, guess what? Most patients we use the term non-compliant with their treatment plan, okay? I mean, I could ask all of you have been patients at some point, right? Have you always done exactly what you were told was your treatment plan? No, of course not, right? So this is really important because we know if we can get patients to do more of the things that are going to help them, then it will improve their health. Now, I just like this picture on the left, Norman Rockwell, classic Norman Rockwell, and why do we need shared decision making? Why do we need to take in patient values and preferences? because in this idyllic Norman Rockwell setting, which probably actually used to occur, the provider, the physician, was there with the family. It was a totally different environment than what we have now on the right, which is, an elderly gentleman in the clinic office, seeing his provider, not surrounded by anybody. So we just, there's no way of trying to pull in patient values and preferences unless we specifically, proactively seek them out in our current healthcare environment. Now, I'm going to focus on knee pain because we've developed a shared decision-making tool for knee pain. And the thing that is so unique about our tool is that it's personalized. And we have there's 8 different treatment options that we basically created through looking at evidence-based care and taking a multidisciplinary group of providers and saying, like, what do you usually recommend for patients with knee pain if you're an orthopedic surgeon or if you're a primary care provider? The tool innovatively adjusts for gender, race, ethnicity, and education level. So it's comparing, it's giving this patient a picture of them in a future state compared to what other people who look like them would be in that future state. Considers the interaction of comorbidities and really promotes the individual seeing themselves in the tool. And it's free, okay? And it's all web-based. Now, you can't ask me any questions about how we actually developed the tool, okay? Because we had really smart people at Johns Hopkins Bloomberg School of Public Health, this senior author, Daryl Gaskin, create the background, the working, the guts of the tool, pulling in all this publicly reported data and databases to then say, okay, if you're 50 years old and you're Latina and you're obese and you have these things, what do we think will happen to your knee pain and your function with time? So, technical questions, I'll refer you to Dr. Gaskin, but it's basically using what's called a Markov model. All right, so here on your right, you see an actual printout of what the output of the tool looks like. This can be printed out, given to a patient. You could scan it, save it as a PDF in your EMR. One of the most important things is that the tool has as one of the 3 options and always includes doing nothing, because a lot of times people do nothing. And I've already mentioned it's personalized, the statistically likely outcomes for similar patients, and basically shows future versus current states, multiple treatment options. So I know you can't see all that very well on the right. We're going to do some larger pictures in a moment, but these are the tool inputs. So gender, age, put in height and weight so it will calculate BMI, hypertension and diabetes as comorbidities, race, ethnicity, living arrangements, marital status, highest achieved education level, that is a proxy for financial productivity, okay? The tool will actually give people a projection of a financial impact to them of different treatment options. It works pretty well for low-income people. It's not going to work well for high-income people. But the tool is, we believe that the tool really needs to be targeted to those people that are where the disparities are greatest, and those tend to be communities of lower socioeconomic means, and then type of insurance. So those are the inputs to the tool, plus their pain level and their functional level. So it's pretty simple to input this data. We designed it so this is not so that a physician is not the person using this tool with the patient. Ideally, it's someone who has some clinical experience and knowledge. Easily a nurse, could be somebody else on the care team who's trained to do this, who may not be a licensed medical provider, but someone who has some clinical knowledge and can work through it. Okay. Not advancing. Let's see. All right, let's audio. There we go. All right. So this is the knee pain output. So this patient has 8 out of 10 knee pain today. If she does nothing, you can see the progression of her knee pain over the years. If she adopts what we call lifestyle modification, which is the second option, lose weight, exercise, over-the-counter medications, and occasional injection, you can see her knee pain significantly improves. And it stays, 3 for over 5 years, and only gets to 4 to 5 at 10 years. Now, if she does medications and injections and then she has surgery in year 6, she will also benefit in year 1, okay? Prescription medications and injections that Dr. DeGioia gives in the office, those help people. But you don't have to do that, right? And you're still going to get worse by year 5. So there's a clear benefit to lifestyle modification. So the message to this individual is, if you modify your lifestyle, you may be able to avoid having surgery on your knee. If you don't, this is where you're headed. Now, let's look at activity level. So today, this woman is 5, okay? If she does nothing, her function will decline. If she does lifestyle modification, you can see how her function improves, and it stays at a reasonably high level even through 10 years. If she does traditional medications, prescription medications, injections, surgery at year 6, okay, then she also will improve, but that's at the cost of surgery. I didn't put in the financial printout just because it takes more time to go through it, but I will share that when we were designing the tool and we did patient focus groups, again, Tony talked about always design with the end user in mind, right? Like you should take any product and go to the end user and say, what makes sense to you? What would be helpful to you? I didn't know that financial output would be so meaningful, but it actually was. We got feedback from the patient survey groups that this really mattered to them. Breadwinners in the family needed to know how their knee pain progression was going to impact their ability to financially provide for their families. So that can also be a powerful part of the shared decision-making conversation to say, listen, lifestyle modification, right? It is going to keep you functional, it's going to lower your pain, and you're going to be able to continue to be as productive at work as you want to be. Now, so we need to engage patients to be active in their health journey, as I mentioned before. A second way to approach this is emotional connection to others through community. And when I say community, like we are all members of different communities. We have our family community, we have our neighborhood community, we have professional communities. So there's multiple communities that we have in our lives. We can also create communities where we pull patients together to create a community for them. They become the community, but we facilitate the creation of that community. And that's what we've done with Operation Change. Now, I mentioned this yesterday, we can also think about how we're going to leverage the power of technology and platforms to create social communities, which is something that we're doing with my new company, Vori Health. But for underserved patients, they may not be comfortable or have as much access to virtual tools. The Operation Change program is a community-based program. And basically, we would take 40 to 50 women. We would have these groups be what I'll call more culturally aligned. So for example, in Chicago, we had an African American cohort. We had a Hispanic cohort. The program is 18 weeks. It's 3 hours a week. The first hour is some type of didactic education, talk about diabetes or depression or arthritis. We would do education on food. We could do food cooking classes to teach about nutrition. And that's where being culturally aligned is helpful, because the food demonstrations are going to align with the kinds of food that those women are going to make at home. The second hour is some kind of movement activity, as you can see here. And the third is the motivational interviewing, in which the women go into smaller groups led by a facilitator. And motivational interviewing is really trying to help the individual understand what is their personal barrier to making change, right? What is it that's keeping them from making change? And I think I shared this story yesterday, but I'll repeat it. One of our women in Chicago, Latina, she voiced that, it's going to be hard for me to start cooking healthier food at home because my husband won't be open to it. He wants me to cook the kind of food that I cook now. This is what he likes. This is what he wants. So that process with her was, well, you still cook the stuff that he wants, but you make another side dish for you that you can eat that's healthier. So she started to do that. And of course, well, maybe not of course, but unfortunately, her husband made fun of her. But she persisted. She had the support of the group. She persisted. Then what happened? The children started eating the food that she was cooking. Then finally, the husband gave in, okay? And I saw her as that pebble in the pond, that ripple that was sending waves out to the shore. One woman changing not just her health, but the health of her children and her husband. And that's how we change communities, okay? One individual at a time. Now, we have data, we've had more than 5 programs, but the data that I can share with you is on 5 programs, which is about over 200 women. Amazing. I mean, I was blown away with this. 69% reduction in knee pain. I mean, they're not seeing Dr. O'Connor, Dr. DeGioia, right? They're not getting injections. We didn't give them medications. We got them moving. We got them focusing on sleeping better, anti-inflammatory diet, healthier eating, okay? And their knee pain improved. 18% improvement in walking speed. Now that was an objective measure, okay? We timed them walking at the start, we timed them at the end. 18%, I'll take that. That is a tangible result that says somebody's physical health has improved. And 78% improvement in their sense of hopelessness. I mean, these women were almost all of them, borderline depressed. So these kinds of programs can really change the lives of people in those communities. And something that, of course, we want to do here in Pittsburgh, and we're very grateful for Dr. DeJoy's support, and we're excited about getting that going. So I'll close with, I showed this yesterday as well, illness can be transformed to wellness when we move from I to we. And it's going to take all of us together to address women's health, and in particular, health for women who are underserved. So thank you very much. And if anybody is interested in the tool, just shoot me an email. We'll set up a time. We can introduce your team to it. Again, it's free. It's web-based. You could start using it tomorrow. Okay, thank you. All right, get up.
And as a reminder too, mainly for the people that may be listening online, we will have a question and answer period. And we do have a way to take remote questions as well. So and if you're remote, you can start adding questions now if you'd like to as well. So our next speaker is Angela Devaney. Angela is founder and currently runs the company called Go Shadow. Go Shadow was a company based in the theme of combining process with technology, of which one of the tools that has become at the forefront is the What Matters to You tool and approaches. Angela will is also currently, she actually started her career with Institute for Healthcare Improvement as a process specialist in Boston, but has now returned to IHI as a faculty member. So she's continuing that journey on the process improvement side, but I think more importantly, how to combine technologies with process. And I think just as a little tickler too, one of the things we learned about with What Matters to You is although it was initially focused on capturing the information directly from patients, it's a very powerful tool for staff, particularly frontline staff, and particularly now with between COVID and the staff crisis. And Angela has been instrumental at taking this tool from just patients to staff, and I know she'll talk about that, but I think it's a very important theme for everyone to think about, because whatever you're going to learn about use for patients, you can go home and use on your staff as well. Angela? Go ahead.
Thank you. Hi, everyone. Good morning. Excited to see you all. So I couldn't think of a more perfect segue from what Dr. O'Connor was just talking about, because a few weeks ago, a few of us were at her Movement is Life caucus, and What Matters to You really started in this movement of co-design and co-design tools as what we thought very small pockets, and especially in ortho, something that is seen as soft. And we were at her conference in DC with hundreds of people, and all of these clinicians were talking about asking their patients what matters to you as the input for actually determining what the pathway was. And so I can share that I think that this could not be better timed in terms of aligning our tools, clinical interests, and then also with staff connection as well, and really reinforcing shared purpose with action that we can take on a clinical level, as well as supporting staff wellness. So for today, we're going to talk a lot about person-centeredness. Obviously, that's not new to anybody here, but really get into how we can create environments that are not dependent upon necessarily a single individual, which they often are, being the champion, but how there can be a hardwired tools and mentality, really, that everybody espouses, that really puts the patient and each other as staff members and as providers at the core of everything that we do. And I think especially right now, what we've heard is that COVID has stripped humanity for many of us. We're not in person. There's this frenetic, constant movement of getting things done. And so starting with a really simple question like what matters to you helps to realign everybody, whether it's with morning huddles, with staff. We don't know, it's very hard nowadays not to bring what happens at home to work. So we can anticipate and support each other as a team, as well as support our patients to all have better outcomes. So there's a kind of three different parts. I was part of IHI, as part of IHI, really this initial movement of the 2, 4, and with model of patient-centeredness. So even 20 years ago, 10 years ago, some places still now, you do 2 patients, right? You just like the paternalistic style of medicine, you are not necessarily doing anything with them or engaging them, but you're acting to them. And so this movement, again, these tools are really focused on the movement from that to with patients, acting with them, acting with their interests in mind, and quite frankly, with our alignment of teams so that we can be more efficient in care delivery as well. This is a very old quotation from 2001, but it is still very, very pertinent. Patient values guide all clinical decisions. So I will go even one step further than that and say patient values guide all clinical decisions and actually the environment of care that is created in healthcare right now. And I think getting back to basics is really one way that we can do that and really reinforce the culture that is created in environments today. So I will say that the service delivery side of this, culture is key. I've spent the last 4 days, I think, 3 days, outside of Philadelphia doing listening sessions and site visit with a facility that's very focused on high reliability. And you can have all the clinical metrics in place, all the huddles, all the lean technology. If you don't have the culture and the buy-in from people, it's never going to work. And I think people realize that now from a leadership level all the way down. And so figuring out how to merge leadership priorities, which sometimes are ever-changing, as we all know, with what happens on the point of care level, or as they always call it, and many times is now called the front lines, right? It feels like this war mentality of constantly trying to do things. Instead of taking a step back and saying, okay, what's the system of care delivery that's happening here? What is this culture and system of our people? How do we support our people so they can provide the best care possible to our patients? And one of the key pieces of that is two-way communication, not only from a leadership level down to staff, environmental services, everybody in between who play a critical part of care delivery, keeping everybody safe, but also from patients and families through all levels, through all the silos that exist in healthcare so that we can achieve the best possible outcomes. So again, putting stakeholders at the center of everything that we do is really the focus of what we do. We've put together a timeline, and with partners in the UK, there's an international movement that we're all part of that really focuses, they're champions. Nobody really gets paid for participating and doing any of this work, but we do best practice sharing all over the world for how to operationalize this concept of asking what matters, listening to what matters, and then doing what matters. And what matters is really a proxy for having conversations, right? They're open-ended conversations that are meant to get to the core of using motivational interviewing techniques of what really makes that person tick. It could be today, it could be through their 120-day total joint experience, it could be through their 10 years of postmenopausal care. So getting at the core of that and defining that is, again, it's fluid, but the beauty is that you can actually use this very simple, you can use paper, you can document in an EMR, which our partners in the NHS are now currently hardwiring into their EMR for the entire English NHS system. You can ask it at different time points and actually look at the outcome and say, did we honor and achieve what matters most to that patient at this day or over this amount of time? On the bottom are co-design tools that we use to help to achieve those goals in an average time frame. Again, being a process improvement person, I like to have time-bound do what by when goals. I mentioned that what matters to you is an international movement. We share stories, and I'll actually show some examples of a tool that we developed. It was a paper tool that we developed with some partners in the UK last year in 2020, which, as we're all aware, they were actually one of the infectious disease hospitals in London that was most hard hit with COVID patients, and they were locked down. So you can imagine, like us, we were not as hard hit at the time here in Pittsburgh. They went from having massive ICUs, lots of family involvement, to being stuck, not knowing what to do, how to do it, how to bring families to the bedside, which they couldn't do for end-of-life conversations. So this tool enabled them to actually honor and document what mattered most to people at end of life, which is, I would say, the crux of how this movement started. But now what's amazing is that it's turned into a shared decision, really a definition of a shared decision-making tool. So the other key metrics that I want to emphasize is that, again, moving from a clinical setting to actually supporting staff, which is what I currently love most in the era in which we live, we've seen engagement increase by 30% in clinical staff just by using this method of asking open-ended questions, not only for them, but for their patients. They feel that by using this really, really simple motivational interviewing, and you don't even have to call it that because then they think that they need trained, by asking open-ended questions, you can help them to see the value of the care, the purpose of why they come to work day in and day out to deliver the best possible care to their patients. And the patients see that as well. So something else just to think about, we talk about empathy a lot. And empathy is very important. I would say going one step further, compassion, developing compassion is actually, lots of statistics will show empathy is just the initial recognition of somebody's feelings. Compassion is actually the ability to take action from the recognition of those feelings. And if you look at patient experience scores, patient experience, the top box score, patients rate physicians and nurses based on their compassion that they show for them, not their necessarily clinical outcomes or anything else that most providers think, I've spent my entire life learning to be a clinician. I'm going to deliver the best clinical care possible. Yes, that's important. What is more important in the eyes of the patient is actually the compassion and understanding where they are from their seat. So ask, listening, and doing. The concept is collecting real-time feedback, then putting it back into not only the care plan of the patient, but also the system of care delivery for the entire staff. So if everybody is aligned, we all know whether inpatient or outpatient, people are busy, right? There's not constant communication or the ability to stop and do a truly warm handoff as we would all hope there would be. But the interesting thing is that you can actually ask this question, write it down. It could be as simple as what matters most to that patient is that their appointment's on time because they need to pick their grandchildren up from the bus stop. It could be that simple. It also could be finding housing for when they're discharged because they don't have anywhere to go. So when you document this, it enables the care team to actually do what they are trained to do and rally around the patient to say, I hear what you're saying, I see what you're saying, and here's what I'm going to do about it. And that doing, that compassion piece, is what really, if we're going to talk about patient experience scores, which I know many people are very focused on, that's the piece that this tool helps to solve. Shadowing is also a foundational piece of this process. Again, much more rooted in breaking through the silos, addressing and deep diving into root causes of problems through qualitative and quantitative data. But if you're going to say, if a patient says, what matters to me is getting out of here at a decent time so I can pick up my grandchildren, and they're waiting for an hour in the waiting room, we have to address really the root cause, right? If we're just going to do that for that one patient that one day, that's great. But really, that patient's going to come back and they're going to say the same thing. And if it doesn't happen, then it looks like pie on our face. So Go Shadow enables you to deep dive, do process mapping, to really see the forest through the trees of how to address root causes. This is actually the Bone and Joint Center, blueprint of the Bone and Joint Center with a high level, how the patient moves through the office. And the times that you see are collected over a number of patients, number of times, number of providers, so that you can actually start to address root causes through looking at the deep dive of this, which is, okay, so if we need to get out of the waiting room in time, how can we make sure that the time spent there is value add, right? If we're gonna have them do shared decision making, we're gonna have them do a lot of PROs, let's make sure that if they have to wait in the office, when they do come back, that they're ready to go, and that face time that they have with the entire care team is truly value add. The learning, the collaboration and conversation learning tool that I mentioned earlier, developed with a team of people in the NHS. This is applied throughout this entire facility. It's called Royal Free in London, again, during the midst of COVID in 2020, June 2020. And the benefits you can see. So what the process was, this was a test, is really putting it nicely. We developed the tool with a piece of paper. We measured that just by asking what matters, they purely asked that question. They did not, we have a library of other similar questions that we've developed. They just asked what matters to you to inpatients. And 67% of the staff changed some aspect of how they provided care. This is in ICUs, mostly ICUs, and med-surg units in the middle of COVID, with very experienced staff who you would think would be change adverse, and they were not at all. 80% said that they changed some aspect of care to actually listen to the initial ask in 2021. So you can see the first year was new. People were very skeptical. It was COVID. They thought, this is one more thing that I have to do. But there were some good results. This year, 80% of people, same units. Again, it was in the middle of their second surge of COVID. So what we kept hearing was that when we asked this question, the providers felt like they had a directive, right? They could do everything that they were clinically doing, but they could also align that care and the requests that were often very simple. Help me to charge my phone so that I can FaceTime with my family. Help me to get some water because I'm a fall risk and I'm not supposed to get up. Very simple things that were documented and carried forward on a whiteboard or on some of these. I'll show you pictures just shortly. Very, very simple that nurses actually documented and nursing assistants. But the benefit was it was carried forward with the providers so that when the providers came, they showed that compassion and took action from what the patients wanted. There's one of the biggest barriers, I will say, to starting this is the fear that it's going to take a lot of time. And that's universally from any provider. And I'll say care team member, not just physicians. We've shown that doing this takes a minute or less. And yes, there are tips and tricks, and we've developed tips and tricks as a result of the barriers that have been put up. But the honest truth is that people who do it, they get a quick answer, they can take action from that and move on. The motivational interviewing side of this, which Mary talked about, it does take longer. There are ways, and I mentioned this library that we've created, to really focus and drive a conversation so that you don't feel, as a provider, necessarily, I'll say stuck, which is oftentimes people say, how do I not get stuck in a room? This is enabling you to gather information efficiently, document that information efficiently, and then create a plan with the patient, shared decision making, and then to move that information forward. The action plan and then iterating what that action plan is and communicating it forward to the team is another oftentimes challenge. But you'll see these were examples of the papers, they were little cards that we created with Royal Free. And we just said, let's be quite literal and say they said and we did, right? So the nurses wrote down family matters, getting out of bed, support, food, very basic asks. So the great thing was that the nursing as a unit, they could look at this and say, we can address all of these issues right now. And we can do it across the board. So if we know that 5 patients are asking for water at a certain time or to see their family at a certain time on FaceTime, we can then anticipate that other patients are going to request those same things and address them. Again, we iterated the tool for this year. We created a few more questions so that they could actually get more to the heart of what was causing anxiety for the family to create a longer term plan. Again, these are ICU patients, some of which did have COVID, so that nobody was going anywhere quickly. So it felt like asking what matters to you as a single question every day was repetitive. So we iterated on that to gather more deeply rooted information. Again, we aggregated it, and I will say all of these tools are available on our website for free. They're paper on the website. We also create digital versions for organizations or units if they would like to use it as well. And you can see some of the results. Again, this was a small cohort, mostly ICU patients this year, but almost 90% of staff reported that asking the questions enhanced their conversations with patients and their action to focus where they were spending their time to be value add for the patient. That's pretty incredible to do just in a week of time. 80% changed their intervention, and almost 80% said that they learned something new about what patient desires were and what their needs were. The way that we represent this information from my team is both visually, it's qualitative data, right? So it's not quantitative where you can Likert scale rate things. It is quite literally what people are saying, and we take that information, analyze it, categorize it, theme it, and you'll see the statistical analysis on the left is actually what we will ask staff, similar to what we ask patients, and on the right is the word cloud that results from that. Interestingly, communication comes up, both staff and patients, the highest. This is aggregate data from across all of our partners all over the world. It's pretty telling. Staffing and teamwork. Teamwork's usually positive, communication needs improvement, and staffing usually needs improvement. But if we focus on that communication piece and focusing on the listening and the doing of what patients provide, and also staff requests, and in addition to that, we will align the care in the outcomes so that we can move the communication bar down, and you can see the patient experience is actually what brings staff the most joy, not surprisingly. So what we've done now, and this is just an aggregate of some of our key learnings. Again, I'm a process person, right? So we aggregate them, we take some of the very high level, but consistently brought up. So communication is an issue. So we break down that into its own bucket and we say, okay, what are we going to do to address this? Because we know communication is not just an issue for these 50 patients, it's an issue across the board. So where are we going to start? And where are the patient requests specific to that so that we can show patients that we're listening to them? So the top portion is when we ask patients, this is what they said, and then the bottom was actually taking that to staff and to teams and saying, what's a simple thing that we can try to do, hopefully simple thing that we can try to do to address that. And this was an example, but I'll show you something that we've been working on with this international group that I mentioned, who a lot of which are much smarter than I am and are statisticians and love quadrants. But when we look at stoplight reports, right? Stoplight report is visual cues are great, right? And everybody loves them. When we look at visual cues, you can actually take those requests that were on the previous slide and you can map them as a team to understand, okay, where are we going to start? How are we going to strategize? What are we going to do so that we can move the dial to show compassion, address what patients are asking for, and asking for quickly? So this is something else that's on our website. We usually will do this either virtually or with Post-it notes. You can do it virtually with Post-it notes as well. But the whole team comes together and you get to actually co-design and co-produce what that problem solving would be for communication, for example. These are, I'll just go straight to the bottom. Looking at those themes and communicating back to the patient and to the entire care team, I will say, is the thing that is often missing. All week in the listening sessions that I was facilitating at every level of the organization, there was a cry to be communicated with, to give me the why, Tell me the why, that why am I doing this? I don't want a directive. I want to be included at the table because I am the one doing the work. I am the subject matter expert as the nurse, as the environmental service person. And so using these tools right now, we know that coming around a table is very difficult, not only physically, but because of time constraints. Using some of these virtual tools enables that alignment to happen. Again, doesn't take 2 days in a conference room to do this. It takes 30 minutes because you know what the patients are requesting, you know what staff are requesting, and you can put them together and make a plan. So with that, I will thank you all for your time. Again, this could not be better aligned with what Mary was talking about, and I'll turn it back to Tony.
Thanks. Thank you, Ange. And our next speaker is Dr. Alana Petrogallo. Alana is assistant professor in the Department of Obstetrics, Gynecology, and Reproductive Services at Magee. And she's also one of the leaders in the Midlife Health Center. As I mentioned early on, when we were starting this whole idea of the Center for Bone and Joint Health, the Midlife Health Center was actually the very first partner that we brought together because so much of what they're treating with women particularly, obviously, and perimenopausal problems aligns with bone and joint health. So Alana's going to talk a little bit about our collaboration as well as the center.
All right, good morning, everybody. Thank you for having me, and I'm really happy to get to have the Midlife Center be part of the Center for Bone and Joint Health. So I'm going to talk today a little bit less about tools and process and a little bit more about midlife health, bone and joint health, and how we come together. But I'm really excited to take some of the tools that we talked about this morning, the Movement and Life app, to our patients, and also really excited to think about how what matters to you relates to staff. I think that's a really interesting thing for us to incorporate. So, all right. Where do we hit this? There we go. Okay, so I'm going to start with an introduction to the Midlife Center at Magee. I'm going to talk about menopause and bone and joint health because it's very hard for me to talk about anything without talking about hormones for a little bit. I'm going to talk about the personalized care approach that we take at the Midlife Center, and then the experience that our patients have had thus far with the Center for Bone and Joint Health. Okay, so starting talking about my favorite subject, menopause. Every day in the United States, 6,000 women reach menopause, and this accounts for about 50 million women in the United States postmenopausally currently. Worldwide, this menopausal female population accounts for about 1 billion women, and it's about 12% of the world's population. So really, a big chunk of the population is in menopause, and something that we should really pay very close attention to. In the United States, life expectancy for women has declined a little bit recently. It's 85 years at this point. But that said, that means most women will spend about a third of their life in menopause. And knowing that perimenopause and menopausal symptoms start as early as age 40, some women will spend 40 to 50% of their life in perimenopause and menopause. So of these women, about 75 to 80% will experience symptoms. So these are symptoms that we're all very familiar with menopause. Hot flashes, night sweats, disrupted sleep, brain fog, painful intercourse, lots of different symptoms that, again, affect most women in menopause to some extent. And unfortunately, these conditions are very often misdiagnosed, underdiagnosed, or totally underrecognized. And additionally, they're also mistreated or undertreated, and sometimes not treated at all. So what we know is that of the 60% of symptomatic women that seek care, only 25% receive treatment. And this particularly hits me because when we talk about women in pain, we know that women generally try to wait longer to seek care, right? We say, okay, I'm going to get through this, and I can get through a couple more years of menopause, and then I'll be done with it. So really, that 60% of women who seek care have already been through quite a lot at the point that they're coming to care. So it is pretty discouraging to know that only 25% of them will receive some treatment. What this means from a dollar standpoint is a really significant increase in healthcare utilization. So in addition to, of course, the time that women take for these appointments, this accounts for about $66 billion per year globally in unnecessary and sometimes necessary medical care costs. What this means from a personal level for women is missed work, and really significantly something that we've seen is a increase in early retirement. So a lot of women have such disabling symptoms and such disruptive sleep from menopausal symptoms that they're forced into early retirement. And they're doing so at a time where they're really at the top of their career. So it's really also a very discouraging thing that we see in menopause. And again, in terms of numbers from a financial standpoint, that accounts for about $150 billion of lost productivity globally. Okay, so, well, it looks like that did not get quite lined up, but at the Midlife Center, the Midlife Center started in 2006 with the goal of addressing the unique issues of women in perimenopause and menopause. So, excuse me, we see women 35 and above, and we treat them for a number of different symptoms in perimenopause and menopause. We treat abnormal bleeding. We take care of women who go through menopause early, so that includes primary ovarian insufficiency or women who have menopause under 40. We treat women who have early surgical menopause. These are early cancer patients, rather young cancer patients. These are patients who have had risk-reducing surgery for BRCA mutations, or women who have really debilitating endometriosis. We treat genitourinary syndrome of menopause, which was formerly known as vaginal atrophy. And then most significantly with this center, we treat osteoporosis and weight concerns for women. So this is where the Midlife Center and the Center for Bone and Joint Health really have their greatest overlap. And so I'm going to talk a little bit about what the role of menopause is in osteoporosis, bone health, and weight health. Okay, so this is a really great slide because I think it really illustrates that menopause affects women from head to toe. I also think maybe I had some energy of the orthopedic surgeons in the audience because I gave this poor woman a bilateral, AKA, to make the slide fit here. So she was in one piece at one point, but again, I just think that it's really important for people to see. We think of menopause and midlife, and we think of hot flashes and night sweats, but really it affects all that you see here, head to toe. I'm specifically going to speak to what we're talking about today with weight gain, osteoarthritis, and osteoporosis, but important to think about all these things when we care for perimenopausal and menopausal women. Okay, so weight gain and menopause. So we know that women gain weight around menopause. On average, it's said that women gain 1.5 pounds a year in menopause. This is not really what we see clinically, and certainly in the time of the pandemic, this is not at all what we're seeing. We're seeing numbers much higher than this, but this is the average weight gain in menopause. And most women come into the office and they say, you know, I went through menopause and my hormones are down, everything's out of balance, and I'm gaining weight. And it is true that hormones play a role in weight gain, but excuse me, they don't play the biggest role in weight gain. We know that lifestyle and aging play a far greater role in weight gain. But what are the factors of menopause that lead to weight gain? So yes, estradiol, which is the predominant hormone, the predominant form of estrogen that the ovaries produce in premenopause, when that decreases in menopause, we see weight gain in women. And we particularly see increase in fat mass and central adiposity or abdominal weight gain. We also see an increase in visceral fat. So in menopausal women, we see about 20% of body composition, 20% visceral fat compared with only 5 to 8% in premenopause. And then we see a significant change in overall body composition. So we see a replacement of lean muscle mass with adipose tissue. We see decrease in physical activity, which further exacerbates the changes in body composition. And we have a decrease in basal and total energy expenditures in menopause. We talked a little bit about mood changes, and certainly mood changes affect a patient's ability to maintain a healthy lifestyle, diet and physical activity, which then further exacerbates the problem. It also changes eating habits. And really something that we see very, very commonly is sleep disturbance. So I rarely see a patient in our office who does not have some sleep disruption or who sleeps through the whole night. And we know that this increase in fatigue, of course, subsequently decreases physical activity. And we also know that women who sleep less gain more weight compared with women who sleep more. So these are all of the pieces that are associated with menopause that lead to that weight gain. Now, the connection with osteoarthritis and menopause is not so clear. We know that there is a significant increase in new onset joint pain in menopause, and this happens in about 50% of women. Interestingly, we see this most with the hands. So my patients who are in their 40s will say, I'm really starting to have joint pain, and they almost always start doing this. It's always in their hands. But what we don't know is what is the actual effect of estrogen on cartilage. So studies have been inconclusive. There are some studies that show that it's probably protective and that estrogen is actually protecting cartilage, because when we look at models of hypoestrogenic states, there's more degradation of articular cartilage. But then we also have studies that show that it might actually be damaging the cartilage itself. So we don't know the exact role of estrogen, but we do know that certainly weight change in menopause affects osteoarthritis. Okay, and then osteoporosis. So the relationship of estrogen and osteoporosis is much more clear. We know that estrogen inhibits bone resorption by managing cell death of the osteoclast cells, which are the cells that decrease and resorb bone. And so what we see is an imbalance of the breakdown of bone with the building of bone in menopause, and that the breakdown activity much more outpaces the building activity. This is really significant because the greatest acceleration in this bone loss is seen in the 2 years prior to menopause and the 2 years after menopause. So of course, the 2 years after menopause is easy. We know what those are. We don't know what the 2 years before menopause are. So really what we try to do is catch patients early and say, let's optimize bone health. Of course, we want to be doing this when they're in their 20s and having peak bone mass. But when we see patients in their early 40s, we really kind of hone in on this so that we can optimize things prior to menopause. We talked about this a little bit yesterday, but the burden of osteoporosis, it affects 8.2 million women in the United States compared with 2 million men. I was really interested in Dr. O'Connor's talk yesterday about the lack of data on men in osteoporosis, which was something that, as someone who only treats women, I was completely unaware of. So, and certainly not what we usually expect, so that was really interesting to learn. But then there's also a much bigger burden in terms of low bone mass or osteopenia. So we talked about this also yesterday. What's the problem with osteoporosis? What's the effect? And really, this risk of 1 in 2 women will the risk of sustaining an osteoporotic fracture in their lifetime is extraordinary. Like, this is more than gynecologic cancers, cardiovascular risk. It's huge. And we talk about, well, what's the morbidity of this, right? Will patients be able to live on their own? What kind of activities are they going to be able to do? Those questions certainly come up. But really, there is a pretty significant mortality associated with this as well. There was a study that was commissioned by the Osteoporosis Foundation, and they found a 30% mortality rate after hip fracture within the first year, which is a big number. So those are numbers that when we have patients that don't quite have a sense of what's the real risk of this very silent disease that we talk about. And of course, a really significant increased risk of subsequent hospitalization and death after a hip fracture. Okay, this is just a quick slide that I wanted to bring up because it's something that we talk a lot about in midlife medicine and something that is very much related to joint and bone pain, which is sexual function and dysfunction in menopause as a result of that. So I very commonly see patients who have hip pain, back pain, knee pain. And because of that, they're not able to engage in intimacy and sexual activity in the way that they would most like to. Also, because of that pain that they have in a shared region, they get some dysfunction of their pelvic floor muscles. And that leads to this decreased flexibility and decreased relaxation, which leads to pain with intercourse. Pain with intercourse then leads to a decrease in sexual activity overall, And then we see worsening of changes to the vagina that are associated with menopause. So it's a very bad circle. So it's something that we talk a lot about in gynecology, probably not so much in orthopedics, but something to keep in mind when we think about particularly hip and back pain in women. Okay, so how do we approach this at the Midlife Center? And part of this is sort of like our quick and dirty of what matters to you, but every visit in my office starts with a greeting and what would you like to talk about today? And so that's what we start with. Sometimes if we have other boxes I have to check off, we get to those later, but the bulk of the visit is what does the patient want to talk about? After we hear those, the next part of our visit is education, and that involves a lot of what I just mentioned to you. So it is extraordinary validating and empowering to women to understand the why. Why is this happening? What can I do about it? Why do I want to do something about it? So those two pieces, I think, are really the most important thing that we do. And then we go into screening that we do for these issues, preventative care and management. And all of those are individualized, and all of those involve shared decision-making in our office. So from a screening standpoint, we do talk about weight, but this is honestly something that we generally don't have to ask about because patients often bring it up. We hear, I have not changed anything I'm eating, I have not changed my exercise routine, and I continue to gain weight. What's going on? So that, we talk about, well, what are you eating? What kind of exercise are you doing? And we try to work with them to find, holes in there or gaps that we can improve to help them. But part of that is really assessing barriers to how they're maybe not having the diet and exercise that will be most helpful to them. From an osteoporosis standpoint, we screen all patients over 65, but we really look to see who else should we be screening. And we know that osteoporosis is underscreened, and I think this speaks to our silos in this orphaned state of the bone. We talk about this all the time, who does the bone belong to? And for some patients, they're PCP orders, they're DEXA scan. For some patients, they see an endocrinologist. Other patients, we do it for them. So I try to take ownership of the bone and kind of steal it whenever I can if it's not been well established, just so someone is really taking care of it. Because this is another place that we see disparities. So we know that all women are underscreened for osteoporosis, but we know particularly disproportionately Black women and Hispanic women are not generally screened. And even after they've had a fracture, they are not properly screened. So we look to get everybody screened. From a diet standpoint, this is another thing that comes up. We ask patients about their diet, or patients will commonly say to us, what's the best diet in menopause to lose weight? And the answer to that is there's no best diet. So really this is also meeting patients where they are. What is their current diet? What are their cultural preferences? What are their dietary preferences? And we try to talk to them about general rules of diet. So we know that calorie restriction is important, but not the only requirement for weight loss and menopause. We talk about goals for calories of 1,200 to 1,500 calories per day and what that looks like for them. So fortunately, we know that from a weight loss standpoint, macronutrient composition is not important in menopause. It does certainly help cardiometabolic factors, but not for actual weight loss. So we can kind of figure out a 1,200 to 1,500 calories for them that might work. We do know, however, if someone really kind of pushes me for a diet, that the Mediterranean diet has really good sustained results for weight loss and for keeping weight off. And also, as a menopause provider, I love that it decreases cardiovascular risk. So if someone pushes me to name one, that's one I'd name. But it's not always feasible for everyone, so we have to keep that in mind. Then we talk about exercise. So we talk about exercise in terms of weight loss and then in terms of bone health. And there's, of course, a lot of overlap between those. But we know from an exercise standpoint that women who are active as they enter midlife are less likely to gain weight through midlife than their less active counterparts. So this is another place. When I see a patient in their late 30s or early 40s, I'm so excited because I can say, hey, if you're not exercising, get to it now so that you set yourself up to be in a better place when menopause hits. It doesn't always happen that way, but that's like the ideal situation for me. What we do recommend, again, is this 150 to 175 minutes of exercise a week for weight loss. But as I mentioned before, we know that calorie restriction alone And we know that exercise alone, is not enough for weight loss. They need to be combined. We do know in terms of exercise for weight loss that resistance improves lean body mass, and it also increases basal metabolic rate, so we do recommend some of that. In terms of exercise and bone density, weight bearing is the key, so we talk about free weights and resistance bands. We also recommend exercises that also improve balance because, of course, we want to decrease fall risk. There are some really good studies on Tai Chi that shows both improvement in balance and improvement in bone mineral density. And then dance, there was actually just a really neat study out of Brazil where they implemented a dance program for midlife women. And they actually weren't looking at bone density, so it's probably not properly placed on this slide, but they showed improvement in a number of metabolic factors and in mood and kind of a sense of well-being with these dance programs. And the thing about it that I really liked was that it goes back to kind of meeting the patient where they are. And so there are a lot of women that would say, yeah, I'd love to take a dance class, but don't give me resistance bands, or like I'm gonna fling it across the room and hit somebody. So there are a lot of good exercises, but again, really picking something that a patient will enjoy and therefore stick with for longer. And then can't talk about bone health without calcium and vitamin D. What we talk to patients a lot about is getting calcium from diet and the variety of ways that you can do that, not just through dairy products. We try to keep patients away from supplementation because we know there's some data that shows increased cardiovascular risk with that, and certainly a lot of GI upset. Vitamin D is tougher, and this is another one where kind of meeting patients where they are, we have to pay attention to that because vitamin D is really difficult to get in diet, and most people are not spending time outside in the sunshine, certainly not in Pittsburgh, but you know, if they can get outside for half an hour a day, they might be okay, but for most women, vitamin D is a supplement. And then management, I'm not going to go into management, but I'm just going to kind of reiterate, as we've said, that management of both weight loss, osteoporosis, it's all shared decision making. So we are fortunately able to take a lot of time to discuss treatment options with our patient. We talk about the risks. We talk to patients about, you know, what is the true risk of osteonecrosis of your jaw with a bisphosphonate? And really those numbers are very, very low. So let's lay that out for you to kind of allay any fears patients have with these. But ultimately it's shared decision making, and we support the patient with the decision they make and then make a follow-up plan to make sure that we continue to take care of them. So I just wanted to talk, we haven't been at this for too long, but I had an opportunity to talk to some of our patients who have been involved with the Center for Bone and Joint Health. And there were kind of three things here that stood out as I spoke to them. The first was not something that they mentioned, but something that I saw as I referred patients, which is, you know, when I'm talking to a patient, I think, wow, this would be a great patient for the Center for Bone and Joint Health. They really get excited about it. They're really happy to know that there's a place that's going to help them focus in on their goals, address these things that they've been struggling with, most of them for decades, quite honestly. And so there's really an initial excitement about it. So it's really nice to have this as a resource to offer people. And then I think one of the other things that they've had a really good experience with is the intake. So I think Dr. DeJoy is going to talk about this again, but sort of the 1 hour intake. Midlife women, like everybody, want to be heard. So the fact that someone sits with them for an hour and talks about what are your goals, what are your hopes, you know, really like getting to know what has their story been to this point is really meaningful and really validating for them, and I think really helps them go on to success with whatever is then selected. And then finally, they really appreciate the follow-up. So, you know, so often a patient goes to see a doctor and here's your plan, go off to it. But these sort of check-ins and follow-ups are things that the patients have really had a good experience with. So we're really excited to continue to have our patients be part of the Center for Bone and Joint Health and to grow with it. So thanks. Get up.
Thank you. And again, we're going to have a question and answer period after my talk. So if you're online, please send your questions in. So what I thought I'd just try to do is maybe put it all together in the how-to mode is we talk about all these different phases, all these different tools, all these methodologies, and use how we developed the Center for Bone and Joint Health. Again, not just for bone and joint health, but how you can think about using the same tools for any care experience that fits into this, where unfortunately there's a lot of fragmented, uncoordinated care across the system, so there's lots of opportunities to improve that. Advance. Oops. So again, just as a reminder, we have to address the issues at a patient level, a community level, and a system level, right? If you're really going to have change, it's great if you could do it for one patient. It's even better if you could do it for a community. It's fantastic if you can develop a system to deliver ideal care experiences and reduce disparities. Bone and joint health, again, is an orphan. It's probably one of the worst orphaned areas because, as Alana was saying, there's just so many different providers involved. There are a lot of different diagnoses. I mean, we haven't even included inflammatory types of arthritis associated with rheumatoid and that whole class, psoriatic arthritis. And women are actually more prone to that too. And that's in this musculoskeletal space as well. So we have to break down silos to really address the system problems. You've heard already about addressing patients' needs as the focus. And again, this can be used for any care experience that any of your patients are going through. And we definitely need to reduce the disparities at the same time of improving care for all. And just a little bit of a background, how we started down this pathway. So initially, it was really focusing on the specific needs of women that are undergoing a joint replacement. So this is our Bone and Joint Center is the surgical part of the program, which myself and I have 3 partners at Magee, and we're one of the, if not the busiest joint replacement center now in Pittsburgh. We take care of men and women. We were one of the first subspecialties really to move there beyond the traditional women's care kind of thing. We've been there for 15 years now, believe it or not. But our focus initially was, and Mary knows this, but I didn't know it, and a lot of people in orthopedics don't know it, there's a whole body of literature in the orthopedic literature that shows the gender-specific differences for patients that have arthritis, how they perceive pain, how they learn, how they do or don't do as well in preparation for surgery, and certainly outcomes for surgery. And it exists, it's all there, and until you go back and look at it, you wouldn't really appreciate it. So our initial sort of entrance into this area was in our own area for joint replacement patients and identifying what was the issues. And we began, and this was all, as I mentioned yesterday, I always say this is one of the good things that came out of COVID, because we were shut down, right? And for 2 months, we weren't doing any surgeries at all. And we had a lot of time on our hands, and it was nice because we took a step back and said, okay, what can we do to go to the next level? And everything I'm talking about actually came from that during the COVID time. So again, knowing this background, we went back and used the tools but talked to our patients, So the combination of the clinical research and what we asked patients, these are just 3 examples that I'll give. The gender-specific differences as far as evaluation and prevention. It was very clear women tend to delay their evaluations. In just in hip or knee pain, it's been shown that women are the last group compared to men to come in even for evaluation. So what does that mean? And for any of these conditions we're talking about, the earlier evaluation and interventions you have, the better off you are in addressing the disease. So right off from the beginning, there were hurdles of why women weren't coming in to get evaluated sooner, so you can provide these interventions. Why? There's a lot of reasons. I do think probably the most important reason, I have 3 daughters, 3 granddaughters too. Women just tend to be the last person to take care of, right? They're always taking care of other people, right? There are other reasons too, but that's probably the most important. But how women learn and want their education and learn about things is different than men. How it's presented to them affects how they learn. There's anxiety that sometimes is higher in women than men about the findings and what the plan is. So you can think about maybe, a woman is a little afraid to come in and get her hip or knee pain evaluated because the first thing she's going to hear about is she needs surgery, right? So just avoiding going into the office to begin with because they're afraid of what potentially could be offered. Number two, as I mentioned, education in the sort of the perioperative period. Women ask more questions than men, and they want to have more of a conversation. We've already learned they're definitely more affected by osteoporosis and arthritis, but there's physical factors too. It's been shown, again, in the literature, that they have worse quadriceps functions, which affects the knees, and worse abductor function, which is the side muscle in your hip, because of the arthritis. So even with the same level of arthritis, if you're a male or female, they have objective weaknesses in those two muscle groups, which turn out to be the most important muscle groups for early return to function after any intervention, surgery particularly. So they, if you across the board, come into any intervention with lower preoperative function, and this is all scored, can be scored, leading to less optimal post-intervention function too. It takes longer to recover. It takes longer for the muscles to come back. And this one was maybe a little bit more of a surprise. And an example was there is a whole body of literature again about how the gender, male or female, perceive pain. And there's a lot in the literature that this isn't just psychological. It actually is physiological too. And we're working with some of the pain management people at Magee deal with pain around the OB experience. And there's a body of literature that suggests that there's literally differences in just the way we're wired and the way we take care of pain. And we do see that, certainly with the post-operative part, but think about it too. In the end, we're treating chronic pain, right? Many of these things, chronic, especially with osteoarthritis. So how you perceive that pain, if it's different, then how you affect that pain is going to be different too. After surgeries too, as I mentioned, women tend to have longer recoveries because of these weaknesses in the muscles. So as we've been talking about, the goal is to improve the care and the care experience for all patients, but we have to begin to also address these gender specific. And that's really where the center came out. We wanted to expand this beyond just orthopedic specific things like hip and knee replacement in preparation for surgery and post-operatively to the broader issue of bone and joint health and gender-specific issues, as well as other disparities. So when I've talked to colleagues and things, the first thing they think about when you say, oh, we're going to start a new center, they think about going to the CEO of the hospital and say, oh, hey, Rich, we want to start a new center, right? And the first thing they're going to think about, new dollars, new spaces, new personnel, right? And it's just a natural thing. So the approach that we took, you can start by developing a virtual center. And by virtual center, what I mean is all the resources already exist within your organization. People, space, everything already exists. But the unique thing is how you connect them all, how you coordinate them all. So it's very low cost in the sense of real dollars. It does take time and effort to pull people together and build the teams and all, but it's a great way to get started because you can go to your president and say, we just want to put this all together in a very unique way. It's not going to cost you a cent right now. Now that said, that's the first step. For instance, again, we just started this during COVID as a pilot, and Alana's patients and our patients were sort of the pilot patients with it. But just recently, we did get office space in a timeshare that we could use. We also just got approval to get a functional coordinator starting in 2022. But we've been doing this for a year, and we have real information to show the leaderships and other people that this is unique and you can do it. So, but a good way to start is think about a virtual center, just putting everything together in a unique way. And you could do it much quicker that way. That's the bottom line with this. So with the center, our goals, mission and goals, was first to co-design coordinated care programs with patients as partners, focus on earlier evaluations, focus on wellness. Remember, this is a non-operative experience, a non-operative center. We have plenty of surgical capacity in the backside if it's needed, but this is really non-operative. Identify and address disparities at the same time as improving the care experience for all. And then develop educational programs with and for patients, the community, and providers. And it's important, I think, to think about education programs for those three groups, okay? You have to develop with patients, for patients, because what their needs are is a little different than the community. It's certainly a step towards the community. It's definitely different when you start talking about to providers. And even within that, what you say to a PCP would be very different than an endocrinologist, an orthopedic surgeon, an OB/GYN. So think about that. And then the last part of it was, as I mentioned yesterday, there's a huge disparity within our own community of orthopedic surgery of first women in orthopedics. But if you look at the area that we're in, it's called adult reconstruction subspecialty, there's less than 1% of the specialty trained adult reconstruction surgeons are female. So there's two thrusts of the initial program. First was the care coordination program and what we've been talking about. I would say, and I see now why Alana's program and ours sort of aligned so quickly. She was doing personalized care already, right? We weren't doing that necessarily for the bigger picture kind of thing. So the theme is a personalized care program. And the way I describe the approach is it's the operating system for the center. It's what really keeps it going, the infrastructure, right, for all the tools that you've heard about. It's an ongoing process. It is based in, we had developed many years ago and continue to use, it's called the patient-centered value system, which is a methodology and approach based in experience-based design sciences to do just this. But think of it as you need an operating system for your center, right? Especially when you have this fragmented system, care delivery system. You have to have themes that brings everyone together. And these are the tools that we've been talking about. What matters to you? Co-design, which is a real science, as I mentioned, and team building. And team building, again, is so important to the implementation phase. But the teams you've heard already are very different because it has to cut across the whole organization from frontline staff all the way up to VPs and everyone in between. And that's what breaks down silos. It's the people that break down silos, not someone from up top say we have to knock down silos. So what matters to you? Again, these are just some examples. This is what patients told us. They wanted coordinated services. They didn't want to have to make 5 office visits for their bone and joint health, right? To see every subspecialist. They didn't want to have to go to separate for nutrition and weight loss programs. But they did want to have those things offered, physical activity guidance, nutrition counseling, ways to reduce anxiety, which I know Mary is a big proponent of, which we really don't appreciate in orthopedics, is mental health is a huge part of treating chronic pain syndromes. And it's another cycle where you get a chronic pain syndrome, which leads to anxiety and depression, which leads to more pain because they do tie together. So that the psychological and the physiological are very, very tightly bound together. So you have to address all of that. And then the other part we always ask are what are the barriers to be able to achieve that, both from the patient side but also the care delivery side. So when you think about it, how fragmented it is, there's low motivation many times from the patient side. There's insufficient time on the infrastructure side, the people side, the care provider side. There's competing priorities for the systems, and there's a lack of direction. In the co-design phase, we definitely design the system around our end users' need. Again, basic theme that brings everyone together. Patients said they felt heard and understood by their providers in the process, and they really appreciated this idea of personalized care. And not a cog in this huge wheel of healthcare. We're really helping to address them and what their needs are. And they did, and obviously it gets back to the follow-up part that Alana mentioned, being able to receive guidance and support along this journey, and it is a journey, it was very important to them. Again, team building can't, again, overemphasize in the sense that's how you implement these kinds of programs. You have an operating system, you have partners, but you have to put it all together. You co-create these programs, and this is the way to scale it and replicate it. We don't want this to be a one-off necessarily just at Magee. We would hope others would take the lessons learned and develop these programs across the nation, across internationally as well. So that's the way you really improve population health over time. So during our journey, after listening to what patients wanted, we began to look around Magee, and Magee had a tremendous number of resources and programs already existing. and how to put them together. So it really started, as I mentioned, with Alana, the Midlife Health Center and our Bone and Joint Center. And yesterday I said, our Bone and Joint Center is unique, I think, for most high volume orthopedic programs in that we do treat 30% of our patients non-operatively to start with. So we had a nice patient population that would benefit from this. The other part of it is we probably deal more with the comorbidities that you've heard about than most subspecialties, because we have patients that are overweight, with very high BMIs, inactive, have diabetes, have heart problems, high blood pressure, are depressed. All those things in our patient-reported outcome studies affect outcomes. People don't realize if you're depressed before surgery or even have high anxiety levels, it affects the patient-reported outcomes after surgery, even though the surgery you could have thought was perfect. So all these factors, we deal with this, and we've had programs we call a reversible comorbidity program to help patients prepare for their surgery. So it was a nice connection, bottom line. And Alana, as I mentioned, Alana's patients and our patients were sort of the first pilot patients to come through. There was an osteoporosis care center, but I think most of that care comes through the Midlife Health Center. We tapped into the nutritional support through the bariatrics program to have a nutritionist part of the team, all non-operative again. And then pain management, but focusing on complementary therapies, not medicines at all. And then most recently, we did, just in the last few weeks, make a connection with Western Psych, UPMC Western Psych, to focus on depression and anxiety in our patients. And they have a brand new outpatient community-based program. It's called the Western Wellness Mental Health Services that we just tapped into. Is that this will now be another ancillary service that we can offer our patients. And lastly, and very importantly, was the Magee-Womens Institute and Foundation, because they helped us sort of bring this all together. And you'll see on the educational side, it was an invaluable connection. And just to show you sort of this is where we stand right now in our pilot. I do think it's truly a personalized care program in action. So if you look at the far left, the startup, the sign up, the referral to the program, again, there's patients that come through our program. They could be operative or non-operative candidates, but they want to postpone surgery, for instance, but they have issues to address. Alana's patients, as you mentioned, there's a huge overlap with those. They get referred to the program. So within a week, we make initial contact with the patient to just do a 10-minute screening, about what they're like, where they're coming from, some basic demographics, that kind of thing. At that point, we then do a very important point is a 1 hour long televisit with usually a phone call. And this is where we use the motivational interviewing tool that Mary's talked about to talk about and ask patients what matters to you. Okay, we think about it, we have a list of services that affect bone and joint health on the one side, which is great, those are the resources. But from the patient side, we want to match their needs with these resources. And we want to do it before they come in for a visit. So it's a one-stop shop. So what we set up is this 1 hour, it's a key 1 hour televisit, because go through all these things. What matters to you, what's important to you, what can we do for you? And then you take that information and we develop a personalized care program. So on the far right, at the appointment, they have a one-stop shop meeting their needs. So maybe some patients want to know about nutrition and weight and exercise, okay? Or they have issues with osteoporosis and arthritis. But we match their needs to the list of services that we can provide. So one of the way I like to describe the goal of the center, as I mentioned, it's connecting people. So I call it the connector, okay? We're not providing all the care for the patients at all, but we're the connector. We're the node point for that patient. So we make the appointment with Alana. We make the appointment with the nutritionist. We make the appointment with orthopedic. So when they show up for their visit, it could be a busy visit, but they're going to have a complete experience based on their needs. And then we do have a follow-up program, and it's usually remotely right now, which patients love. Just being able to check back in with them and say, how are you doing? What are the hurdles? What's going on? So that's continuing. So I will say this is a pilot, like we've said, but we've had, I think, over 60 patients come through, something like that now, and we're tracking this. And right now, the ironic thing is, as I mentioned, as a virtual center, we're using existing resources. We're sort of outgrowing our resources, which is why we got office space and why we got approval to get an APP as a coordinator for the program. So we hope to go to the next level in 2022 to really show how the pilot worked, but then expand it and scale it to other populations. Thrust number 2, again, I think is extremely important, education. And if you look across the board, the only way to really change performance either at a patient, community, or system level is education. And remember how I said yesterday, one of the weaknesses of bone and joint health is many times at all 3 of those communities, they don't even understand what the problem is. They don't even know there's a problem, right? So to engage patients, to engage the community, engage providers, you have to educate them first. So we have a very active educational problem, and it's an active, what I call active education, not passive. We're not just trying to throw out flyers and expect everyone to read it, kind of thing. And it is broken down. And even on the provider side, there's sort of non-musculoskeletal providers and musculoskeletal providers because they have sort of unique needs too. And these are just some examples. Again, this is all free if anyone wants to use it. These are on the patient side. We develop flyers just to explain the problem to begin with. If you can't get across that there's a problem, you're not going to have anyone be able to change behavior. So you have to do this. So we have a series of educational parts. We have a very active multi-channel resources. We have a bone and joint health series that's just a community outreach program. All of these were in person, obviously, before COVID. But we've tried to transfer some to live, but remote, which has been a challenge. We started a Facebook Friday series, which I participated as other providers. Healthy Mondays, Gina is here over the summer. But there's a great time to focus on what to do, start your week off in the best way. And during COVID again, we had a team develop a whole series of exercise videos that's segmented on hips and knees and all kinds of things. So there's a lot of nice resources that we could put together. Other things we have is Discover Dr. D. These are websites that you can learn. And again, many of these are free for people to use and resources. We're very fortunate to, again, partner with the Magee Foundation because they already had an active outreach program into the community. So for instance, this year was the first year we tapped into Girls on the Run, which was a fantastic opportunity because not only we were addressing the moms, but the children too, right? The moms are the coaches and the kids were the runners. But as we said, the earlier you get women particularly involved in understanding problems, the better you're going to be at addressing the issues. So it was a great opportunity to sort of approach both of these groups at the same time. And those are the kind of things that Magee does all the time. They're out in the community. Providers, again, we look at non-musculoskeletal providers versus musculoskeletal providers with this idea that it is a varied group, it's siloed. So we have to improve the community of practice around bone and joint health. As Mary said, community development is one way to achieve the goals. And it really is necessary if you want to have this scalable. And then on provider education, so we in our program never had residents or fellows in our program. But just last year, we decided collectively to develop a very unique fellowship in adult reconstruction surgery, which the core clinical part will be in our center, but also become an active member of the Center for Bone and Joint Health. And it's for women, although we can't advertise that. So we have our first fellow, though. She's starting in August of 2022. We're interviewing for our second fellow currently. So I think it's a big step. And again, addressing this disparity on the provider side, particularly in our area. And hopefully those building the leaders, and we're going to have many traveling fellowships, because there are women that are adult reconstruction surgery like Mary, even though there's few, but there's people with connections in Boston and Florida and others that we're trying to create a link for our fellow with their women that are already in practice too. And as Mary said, the next steps for us in 2022, we hope to be one of the next sites to implement the Movement is Life Operation Change in Pittsburgh. And I always call it, borrowing brilliance instead of stealing ideas, but borrowing brilliance to apply that in Pittsburgh. And Mike and the foundation are also helping Megan, helping us to approach Pittsburgh foundations to support this as well. So if you'd like to join, we call it the neighborhood, discoverdrd.com is a good place to start, because it sort of covers all of these areas. There's lots of free resources for people to download or use. If you want any additional information, you certainly, I'm sure any of us, more than willing to send us an email. We can direct you in the right places just to help generate that community of practice. So with that, if I can ask the panelists to come up, we're going to have a question and answer period. And again, if you're remote, we have 15 minutes. If you are remote, please send your questions into. So, yeah, Mike, come on up.
First of all, I thought it was great. And I have a comment about your having the pond example. We have some real research around the fact that is quite significant, and it happens more often than not when the caregiver receives treatment, particularly for drug and alcohol abuse and things like that, where we try and treat the family through the mother and the mother, the baby through the mother and the mother through the baby, right? I'm wondering if potentially that wouldn't be a significant component of what you guys could do, which would be to provide sort of intervention strategies for the family based on the mother. It seems like a natural fit and something that worked really well.
I think thank you for your comments. Absolutely, those are great ideas, and a natural evolution of how you could further develop the program. But we have to, walk before we can run, sure. Right? And it makes sense to expand this concept of creating a community not just for women, but also for men. So, and then families. So I love that comment. Absolutely, it's a journey.
Thanks.
Megan?
I was very interested when you spoke about creating that sense of community, both in person through the Operation Change Group and then online through the virtual tools that you've developed. I wondered if you could speak a little bit to the high points and challenges of each of those platforms.
In terms of the in-person communities that we've created through Operation Change, it's interesting because, a lot of those women, they never knew each other, even though they lived in the same area. And bringing them together within this structured program, you're there because you have knee pain and you're heavy and you're in pain, you want to do something about it, gives them some commonality right from the start. And humans by nature are tribe-driven, right? We need to feel that we're part of our tribe, that our tribe accepts us, that we're loved, that we love our tribe, all of this. We're very social beings. So I think it's relatively natural to create these in-person communities. Online communities, a little bit different, and we're working on building our virtual platform for that right now. So I don't actually have data that can say we think that virtual online communities can work as well as in-person communities. They may not work as well, but they can still provide support in ways that you may not be able to do in person because people can't always get to an area for an in-person meeting. It's certainly more convenient and easier to do something online. And there also may be some individuals where a certain degree of anonymity, they may feel more comfortable actually in that environment than when they're face-to-face. So I think we need multiple strategies, right, to meet people where they are, to get out to what matters to them, and have lots of tools in our toolbox in order to get to the solution.
Thank you very much.
You're welcome.
Jess?
Hi. Thank you to all of our panelists for really illustrating this, I think, unexpected but very interesting intersection of orthopedics and midlife health. I think it's something that none of us really probably spend a lot of time thinking about. But my question is really for Dr. Pietragallo. It seems like early intervention is key here. And how do you convince your women, your patients, who maybe aren't feeling hip or knee pain to go to something like the Center for Bone and Joint Health when they come to you with sleep disturbances and weight gain, and and their focus really probably isn't on their joints or their orthopedic concerns? How do you move them in that direction?
You mentioned something that's really powerful, which is the weight gain. So women in midlife are so motivated by weight that if I can tell them part of this program is nutrition-based, part of it's exercise-based, they're usually very excited about it. So women in midlife are really interesting because, like, on one standpoint, they're a sandwich generation, and they are taking care of kids and taking care of parents also. But on the other hand, they're like finally starting to take care of themselves a little bit and realizing it's time for me to take care of me. So honestly, like, giving any tools to do that is usually like eaten up very excitedly. So I would say the pain part of it for our patients is not as critical as the help me get into some kind of an exercise and movement routine that will be helpful for me, help me achieve weight loss that's been eluding me based on what else I've been doing. So it's not a hard sell, but osteoporosis is a little harder to sell. But
Yeah, I think to add on to that,
Yeah.
we see it all the time, pain is a huge motivator. And we've had patients change their lifestyle to be qualified for surgery because we did give them, guidelines and rules and, all that. So pain is it's awful for the patient, but giving them the hope of pain relief is a great motivator, I think. So, that's something to consider too.
Jess, I'll make one more comment. And I guess this will be a shameless plug for my first book that will come out in October of 2022. So you can all buy it for all the women in your lives that you love, okay? This was about a year and a half ago. I came up with this idea, and I have a co-author that, we need to empower women. Women as patients need to be more empowered with how they can engage in their health journey, right? Mm-hmm. So, because I see this all the time in ortho and musculoskeletal. And I am given the same educational talk over and over and over again. So I started to look, what kind of books are out there, women's self-help medical books, aside from the classic Our Bodies, Ourselves. Mm-hmm. And there's all kinds of books that are focused on reproductive health. But there really wasn't anything that I could find that was more across all kind of common clinical conditions, and then talking about unique health needs of women, LGBTQ community, bias, all kinds of topics. So I started on this project, and then I guess it's my year of entrepreneurship, right? So then I had to see if I could find a publisher, which I did, Mayo Clinic Press. Thank the good my old Mayo Clinic connections. That was helpful. And we structured this book. What's the condition? So common clinical conditions. Why can you prevent it? Why does it impact women more? What questions you should ask your provider, and pearls of wisdom. And these chapters are short chapters, 800 to 1,200 words. To give this person, this woman at home or her daughter, here's what I can go to as a guide that's going to give me some basic education about whatever it is. COPD, osteoporosis, right? And hopefully help them ask better questions and be more engaged. And I'm actually going to go look if we have a chapter on what matters to you. So the deadline will be very quick, but it might. I was just thinking, maybe I can still squeeze a short chapter in. Hint, hint, Angela. I'll be emailing you. We'll see. I'll check with the publisher. Anyway, it's amazing. I was shocked. Like, this book already has to be out there, but it wasn't.
Yeah. And can you tell us the title, or do we have to wait for that?
I'm so sorry. The title, this is what made me think of it. We came up with the title, Taking Care of You, The Empowered Women's Guide to Health.
Okay. Thank
Because
you.
it's about women taking care of themselves. And the book is to give them tools and education so they can ask good questions when they go in to engage with their provider.
Great,
So
thank you.
anyway.
Thanks.
So Angela, the one question that came up from the audience is that, how, even though we talk about what matters to you, not requiring a lot of time and all, I'm sure you've had some resistance and all. So how do you both overcome that resistance, but also engage patients and staff to participate in what matters to you?
It's a great question. So I think during COVID especially, what we learned is that everybody is burnt out, not burnt out from not only the frenetic day-to-day activities of home and life and living with constant anxiety, but in addition to that, not necessarily trusting the system in which you work anymore because of the constant change and not knowing the why. And so how we started was there was this bottom conversation that was happening that was spreading like wildfire around trust and the constant changes, and we never get asked what we do day in and day out and how these changes affect us. And then from the top, hearing from leadership the exact same thing, but in a different sense. But the leaders know they need the people who are at the point of care to continue to do what they do, but this paternalistic style of top down, I'm going to tell you what to do, and if you don't do it, there are going to be repercussions, as we all know, is flipped on its head. And so it was very easy to motivate leaders again. I'll go back to partners in the UK, a similar system to UPMC, 15 to 20 hospitals, spread very widely, 15,000 plus employees. And she said, we need to do this, and we need to do this now. And so what we did, and luckily her leadership, we didn't just ask what matters, we asked, how can we support you? She realized at a leadership level that trust was completely fragmented at the core of the care delivery system. And so we developed what was an online survey at the time, and in year 2 became multi-pronged because people do like anonymity, and which is really important. We made it anonymous as well as a team-based discussion tool so that they have incorporated into huddles and things that they already have. They have this, what they would call value-added time, to actually debrief what's going well, what's not, how do we collectively want to improve that, and let's communicate that so that we have a shared voice to actually move forward. So I'll say that it usually comes from both the leadership recognizing that there's a need but not knowing what to do, and then also from the bottom up recognizing that there are a lot of shared problems and shared concerns and trust issues, not just that are unit specific, but that are organization specific or system specific. And so the buy-in was easy, and I will say that we figured it out as we were going, but the concept of it not being a standardized survey and it being a conversation tool that then you can actually analyze and report on and iterate on was something that people were gravitated to immediately, because they could see actually what those themes were to allocate from a leadership perspective their resources really quickly.
And this is probably for Alana and Mary. So anytime you start something new, and this is very much we've talked a disruptive process, right? It's not just a little change, it's a big change. And there's always just challenges. So, I view us as champions here, but maybe Alana go first. You have partners, you have partners in your own area, but across OBGYN, I have partners, what do you think you would tell them to get them interested? They don't have to be champions, we found, but you have to get buy-in at some level. So what would you be telling your partners about the benefits of buying into the themes?
I think I would probably reiterate things that patients told me. So really like giving patients this other experience of being listened to and being asked what's important to them, what their goals are. And that, I think as providers, we all want to increase those moments and those touches with our patients where they get to do that. Again, I don't think it's that hard of a sell. It's such a great program for people to say, this is coordinating all these things that, we in our clinical practice don't have the capacity to coordinate all of these things. So that's how I approach it within our group. But again, we have a special population. So.
I loved Angela's comment about how important culture is, because it is not just about culture, it is all about culture. I cannot agree with you more strongly on that. And it's amazing to me how difficult it is to change culture. And how gratifying it is when you make progress. So I'll just make a comment. I think that becoming more facile at change management is what we as leaders need to do. And one of the books that was very, very helpful to me when I was doing this big change management program in the ORs with surgical safety is the book Switch. Shrink the change, shape the path. It just really helped me get people to do simple, we're talking about a briefing before surgery and how much resistance there is to surgeons talking to the team before the surgeries start. So, basically, I had to mandate, okay, here's your, I'm going to create a form, I'm going to shape the path, I'm going to make it easier for you, I'm going to shrink the change, you only have to do this once in the next 2 weeks. You got to show up in the OR 15 minutes early. Surgery time's at 7:30, 7:15 you got to be there with your team talking about the cases and the patients that you're going to do that day. And let's just try it. So everybody had to do it. There was whining, of course, right? Because you would think that 15 minutes was like the end of the world, right? That was the most valuable 15 minutes in the entire day. But everybody got through it. And then the feedback from the OR team, right? Talk about team building and valuing your team members, amazing. And we just expanded it. And then to the point where everybody did it. And it just became part of what we did. That's the same approach with what matters to you, right? Shrink the change, tell people why it's important, give them the feedback. I had a team board, posted the outcome and the results, here's the time frame, the goals, all the stuff that Angela presented. But everyone that's out there working on culture improvement, keep going. It's tough, but you can do it.
Yeah,
That's fascinating because I love to hear this because physicians that lead.
Can you come up to the mic,
are rare.
Gary?
Physicians that truly lead change are rare. Physicians who want to make change and lead, they're the difference makers. They really are. And that's in all of society in every profession, right? It's not unique to physicians. It's mankind. It's how we're built. Everybody's built a little bit different. But when you want to change something, if you can communicate that on a level down to the lowest staff, it percolates. It percolates down, it percolates up. I don't know if that makes sense, percolation, but it truly does. So one of the questions I have is, how do you sustain it? You guys as physicians and leaders go 9 million different directions, 9 miles an hour, every day, 365 days a year, no matter what you do, personal life or professional life. How do you sustain it in your organizations? That's a real challenge, I think.
Well, I'll just answer briefly. I think that you find new areas that you want to make a clinical improvement. And then the team aligns around how you're going to do that. You do your PDSAs, right? Plan, do, study, act. You give feedback, you set goals, you share the results. And I think one of the challenge for us as leaders is to recognize, is for us to continue to grow and learn new ways to do things. And I'll just share, like I had this one moment, now that I was like amazed, like, duh. So we started with preoperative briefings, got everybody doing briefings, and then we start with debriefs. Okay, now, what did you do well? What went well? What could we have done better? Were we missing any equipment? Those were the 3 simple questions. And we started doing it and got everyone to start doing it. And then I'm in the OR one day, and when we're closing, that's when we would do the debrief. And everybody had to document this, like, so I could have a little sheet. So why? I could then tabulate defects and identify opportunities across the span of different surgical teams. Okay, so I was always leading the debrief. And then one day, I'm like, why am I doing this? Why am I not empowering the other members of the team to lead the debrief, right? And it was just one of these aha moments for me. And I'm like, I probably should have learned that before. Like somebody could have given me more feedback to learn it. And then we started taking turns. And it was amazing, particularly when the lowest person on the hierarchy, right, the surgical tech, who had been with us for years, I mean, Ron, you lead the debrief today. So he starts off, what went well, what didn't go well, and he specifically made a comment about the resident that was with us. And there was something that the resident hadn't done well that we had to go back to, fix, basically. And then as soon as he said it, he started to take it back. Well, I didn't really mean that, and I said, no, we do mean it. This is how we learn. If we can't have the psychological safety that we need to give each other honest feedback, then we can't improve. Mm-hmm. And she knows that she could have done it better, and I know, and we addressed it as a team. And unfortunately, we actually always learn more from the things that don't go as well as the things that do go well. But it just takes a consistent effort to get people to that point.
And I think also, in addition to that, you have to build it into something that they're already doing. So this, what went well, what didn't, and the how can we improve it for next time, right? That how. It's built into, yes, it might have seemed like 15 minutes was an hour to begin with, but they're probably already doing a timeout at the beginning and huddling beforehand. And I think that that's a key piece as well, initially, to spread and sustain, but then also when you start to elevate the voices of that surgical tech will then go and Ron tells all of his friends, hey guys, look what I'm getting to do. Or you do the same in central sterile, and you start to bridge these connections where there's genuine interest, you're reinforcing that they have a voice in the team, that their voice is not only represented, but it's actually being heard and taken action from. And they can see the real results of that. And whether that's, a surgical tech or, a CEO level person, it's critically important to get buy-in and spread.
The one thing that I'd say that we don't do well, and it's really hard to measure, is the efficiency that you gain from those newer activities. Like what happened when we started doing the briefings, right, is the pages in between cases essentially went away. Why? Because the team already asked me, Dr. O, do you think you're going to need a Midas Rex for this case? No, I don't think so, but Mel, that's a really great idea. Why don't we have it available but don't open it? No, she doesn't have to call me in between cases to say, hey, do you think are you going to need this? And so I immediately noticed, like, all of a sudden, there's less interruptions, but it's very hard to actually measure those kinds of benefits from that activity. But there was, I'll share, there was a little bit of some challenge because we first started doing this with the orthopedic team, and then all our orthopedic staff, OR staff, basically started going around saying, you know, like, our surgeons talk to us in the morning. Okay? Our surgeons brief with us in the morning. Like, and your surgeons don't. So that created a little bit of friction until we were able to roll it out. No, I'm serious. There was some friction like, oh, you guys think you're better than us. Well, our surgeons think we're good. They're talking to us. So we had to mitigate some of that.
Competition works too.
It does.
Well, we're out of we're out of time today, and I'd like to thank the panelists for participating, especially Mary for coming in yesterday and today. She set the stage for all the opportunities for improvement, right, that are coming up, which we hope this is one of the first steps that we'll start to develop community practice and best practices too.
Excited to work with all of you and delighted to be here, and
we appreciate
love
it.
Pittsburgh. I grew up in Newcastle. I'll be headed there later today to see family, so thank you all.
You're welcome. And thanks for the audience and whoever's online too for participating. If you have any requests for information, like I said, we have lots of free resources available. If you have questions, I'm sure all of us would be more than happy to answer any questions by email. If you have suggestions too, and we hope this will become part of the offering during the Magee Summit in the future as well. So thanks
Tony,
to everyone.
can I make one more comment?
Sure.
I'm not sure that everybody here appreciates the gem that you have with Dr. DeGioia. He wouldn't want me to say this, but he is truly an innovative leader in orthopedics. I mean, there are not a lot of other people like Dr. DeGioia out there. And so sometimes we don't recognize what we have in our own backyard. And he has assembled this incredible team. Look at Angela. Look at Dr.
Pietrogallo.
Thank you, thank you. So I just want to thank Tony for inviting me. I have so enjoyed the meeting and my visit with you all, and just to highlight to you all how incredible Dr. DeGioia is.
Thank you very much.
And team.
And team. Well, we had a saying when we were back in the old robotics and navigation system, there's no such thing as a local expert.
Exactly.
Right? So, but that's why we asked Mary to come in too and give us everything. But thanks to everyone for participating. Have a good lunch.
Very nice.